Good morning, students. This is Neonatal Diseases. This is your overview for Module 2 in our neonatal respiratory pathophysiology section, and this will help us prepare for the clinical simulations that will follow. So the first condition we're going to discuss is respiratory distress syndrome, or RDS, also known as hyaline membrane disease. This is one of the more common ones that you'll see as a respiratory therapist, even though it only occurs in 1 to 2% of all births, and in 10% of all premature births. Since we are going to see a lot of premature babies, you will see this occurrence quite often in your career if you're working in the neonatal intensive care unit. Some of the predisposing factors we've talked about sort of before in the RCP 110, 111, and probably in pathophysiology class as well. But prematurity, the more premature an infant is, the greater likelihood the child will have RDS. In fact, you can pretty much count on a child less than 26 weeks having RDS. So there's a inverse relationship. The more premature, the greater the percentage. The total percentage I gave you was really just a percentage of the overall birth rate percentage, not the percentage that you will see, simply because everybody coming to the NICU will likely have RDS. Fetal asphyxia and hypoxia. When the baby's in utero, sometimes the cord will get wrapped around the neck. Now, it's not because it's wrapped around the neck as much as the cord is prolapsed or the cord is torqued in some way around the neck, which restricts blood flow, causing hypoxia in the infant. This is because there's a reduced blood flow going back to the placenta, which is the gas exchange unit for the mother to the baby. The other factor is maternal diabetes. Mothers who it's pretty common for mothers to have diabetes developing during pregnancy, and this also increases the chance of premature birth. In some cases, periods of reflex hypoglycemia in the fetus will result in impaired surfactant production. Keep in mind that the three aspects of surfactant, it has phospholipids, it has proteins, and it has carbohydrates. So a reduction in sugar will result in a weakening or a reduction in the production of surfactant. Now, how does this affect the infant? Well, if you look at the right side, the left side here, surfactant activity, remember the purpose of surfactant is to reduce the surface tension of the lung. This keeps the airways open. Well, if the airways aren't open, they're atelectatic, or we develop atelectasis. This is a progressive process. As the lungs deflate, you develop more hypoxia. The hypoxia is because of the reduction in gas exchange. So technically, you get hypoxemia followed by hypoxia. Because we have lack of oxygen, we develop a metabolic acidosis, and that's really due to lactic acid building up. The infant will work harder to breathe. Unfortunately, the work of breathing increases so much that the airway gas exchange is impaired, and they develop hypercapnia, or an elevated CO2 level. This also results in a respiratory acidosis. So they develop a metabolic acidosis and a respiratory acidosis from the inability to properly inflate the lungs. Now, this whole process causes damage at the capillary level and actually can result in alveolar necrosis. One of the reasons tissues will die is because there's a lack of oxygen being delivered to that area, and then that causes the tissue to break down. If you follow the pathway this direction, you'll notice that all of these things also lead to a change in surfactant production as well. So in other words, deficiency of surfactant increases with these factors. So the cause of the condition, which is surfactant activity is reduced or not being produced by the type 2 cells, results in atelectasis, which ultimately increases the deficiency even more. So what this means is, if the lungs can stay inflated, we can help improve surfactant production and delivery. Now, if a child is too young to produce their own surfactant, then we have to provide that surfactant, and that process is done usually within a few, well, preferably within 30 minutes after delivery, but it can even occur several hours later. Most likely in infants less than 26 weeks, it'll be done fairly close to delivery. The other thing that the acidosis and the hypoxia will lead to is an increase in vascular spasm. Now, ironically, this leads to pulmonary hypoperfusion, which results in more of the hypoxia hypercapnia. As you can tell, this sequela of events continues. Hypoperfusion is also due to the fact that the baby is born with a low oxygen level already, which increases that vascular spasm. And so this whole cycle will continue. More hypoperfusion, more atelectasis, decrease in surfactant production. So how do we correct this? We'll talk about that in our cases, but basically we're going to try to correct the atelectasis and we're going to try to correct the surfactant deficiency. That will resolve this side of the graph. Now, what does surfactant deficiency do? This gives you a decrease in functional residual capacities. That's essentially what atelectasis is. You increase right to left shunting. Now, if you'll remember from the discussions we had in cardiopulmonary anatomy and physiology, you can have a right to left or a left to right shunt. A right to left shunt simply means that the blood either completely passes by the lung, goes from the right side of the heart to the left side of the heart, out to the body before undergoing gas exchange. Now that can occur extrauterine and intrauterine. Intrauterine is normal. Extrauterine it is not. In other words, once the baby's born, a right to left shunt will impair oxygenation even more. So this leads to right to left shunting. Why? Because the ductus arteriosus remains open. That means blood flow will somewhat pass through the ductus from the pulmonary artery directly into the aorta. Of course, what will happen is this will result in the baby breathing harder for a period of time. But a baby's stability when they're first born rapidly decreases and they will actually stop breathing. So they may have initial increased work of breathing and you'll see attempt accessory muscle use. What you really see is retractions, you'll see grunting, nasal flaring, and they will really be struggling to breathe. So that increased work of breathing doesn't necessarily mean that they're really improving their breathing process. In fact, because their chest cavity and their thoracic cage is so flexible because their bones haven't hardened yet, the increased work of breathing is detrimental to their breathing process in this case. Whereas as an adult, when we increase our work of breathing, it can offset some of the changes initially until we fail. But the baby will fail quite quickly in this case. Hypoxemia and hypercapnia are really the result of a ventilation perfusion mismatch. We have a reduced amount of blood flow going past right here. We have the pulmonary hyperperfusion. We have a reduced amount of blood flow going past the lung. That results in the ventilation perfusion disruption. So in other words, we have a reduction in perfusion, which means ventilation is greater than perfusion. On the other side, atelectasis, this means that we have a reduction in ventilation. So we have both. And this is really truly a VQ mismatch. So what happens? Atelectasis then results in a higher pulmonary vascular resistance. That means an increase in pulmonary artery pressure, more lung hyperperfusion, and right to left shunting occurs across the ductus. And it can occur across the foramen valley. Now remember, the foramen valley normally closes right after birth. And this is because of pressure on the left side of the heart. This valve closes, and after a couple of weeks, or a couple of days actually, it will be completely healed and it will no longer open. But early in birth, right after birth, the perinatal phase, there's a high risk of that valve opening back up. So what that means when that happens is that the pressure on the left side is now lower than the pressure on the right side. Now remember, the right-sided heart pressures are normally much lower than the left side. That's what keeps the valve closed initially until it heals. So what happens? Hypoxia, well, technically hypoxemia and hypoxemia leads to hypoxia or tissue, low levels of oxygen in the tissue. We get anaerobic metabolism, thus lactic acid. This damages cells. Lack of oxygen to the tissues results in necrosis or damage and then eventually remodeling. We'll talk a little bit more about the remodeling, but essentially, this child will go on to develop what we call bronchial pulmonary dysplasia if not treated properly. So this cycle will continue unless we replace the surfactant. Symptoms appear quite often sooner than 2 to 6 hours, but just be aware if it doesn't appear quickly, within the first couple of hours, doesn't mean it cannot occur later. Now, sometimes it doesn't occur immediately, and that's because there is sufficient amount of surfactant. But as the lungs actually, as the baby works harder, the atelectasis will occur, and then we'll have more surfactant deficiency. The initial disease process will peak at 48 to 72 hours, and it takes anywhere from 5 to 7 days after birth to recover. Now, this is assuming we treat it properly with surfactant therapy and adequate ventilator support. Some of the things you might see: baby will breathing fast, tachypnea, retractions, nasal flaring, grunting. Now, grunting is actually a natural mechanism that it's exhalation against an open glottis or partially closed glottis. And the sound that you hear is called grunting. Now, when you hear this, remember the child is in distress and will progressively get worse if we don't interrupt this process. Now, of course, all of this does. So in combination, if the child had all of these problems, we would go ahead and put them on nasal CPAP at the bare minimum and possibly intubate them, give them surfactant therapy. Breath sounds will be increased with crackles. Remember that babies typically don't wheeze because they don't really have smooth muscles. Now, babies in their lungs yet, so that it doesn't spasm. But keep in mind that babies also, when they're first born, will have crackles because of fluid during the birthing process has not been completely cleared. But what this is referring to is the babies has atelectasis and they have the lungs are going to be more fine crackly than wet crackly, which you get more wet crackles right after birth. Cyanosis on room air. So the baby will turn blue very quickly if they get into real trouble. And keep in mind, unlike adults, it happens within, it can happen within 60 seconds or 30 seconds as the baby begins to shut down. Hypothermia and hypotension are also things that we have to watch out for, as partially because hypothermia will blunt their response in terms of how they would respond. In other words, normally in hypothermia, it's going to slow them down. So that means their breathing pattern will not be able to keep up with the fact that they have lack of oxygen. They will become hypotensive as their smooth muscles of their vessels begin to relax. And this is in response to the hypothermia as well as the hypoxia. So what we initially possibly will see is a respiratory alkalosis on a blood gas with hypoxemia progressing to a respiratory acidosis with significant or profound hypoxemia. You'll get an increase in bilirubin, partially because this is pretty typical even if they don't have RDS, but even more so because of the decrease in perfusion. Now, bilirubin, remember, is processed by the liver. So oftentimes these babies will also be under a Billy light in order to convert the bilirubin from a unconjugated to a conjugated form to be removed from the body. Hypoglycemia. Because the baby's under stress, they'll be burning sugar. As they burn sugar, it results in a low blood sugar level or hypoglycemia. And of course, they might also have a decrease in hematocrit. Now, as they get older, you will see oftentimes they will have an increase in hematocrit as a compensatory mechanism, but early on they may also have that decrease in the hemoglobin as well, mostly the hematocrit. So that means they will have a certain amount of or extra bleeding time, if you will. So we have to watch that. This is what the chest x-ray would look like. And actually, on this PowerPoint, it doesn't show up as clearly. So I'd ask that you refer to your textbook. But it gives you this ground glass, normally gives you a ground glass appearance. Now, this one is normal x-ray, but it looks like it has a ground glass appearance, and that's really not the case, because this is, again, it's a poor x-ray on the PowerPoint, but you can see that it's a little grainier, and the lungs, if you look here, are much more well expanded. And then here you can see there's more white here. Now, of course, some of that is the grain is from the film itself. But if you'll refer to your book, you'll be able to really contrast that. And of course, you also may have air bronchograms, and I'm not sure you can see it that well here, but an air bronchogram is where we have hyperinflated airways. Distal to that is the atelectasis, and this is a hallmark of RDS. The other thing are the densities that will surround the hilar region. Now remember, the hilum is where the trachea is attached, and what extends from this are lymph tissues. Now, what happens when surfactant is decreased? Well, remember time constant, that's resistance times compliance. What happens is elastic resistance is very high. So this means that compliance is low. That will reduce the amount of time it takes to fill up the lung, which means we don't want to have a very long inspiratory time if we're going to be ventilating these infants. So somewhere between 0.3 to 0.6 seconds would be the maximum amount of time. So we have a decreased compliance. Now keep that in mind, that decreases the time constant. So we're going to initially be supportive in therapy. Neutral thermal environment, which would be body temperature at 37 degrees. Maintain the normal perfusion, that may mean fluids. Ventilation, oxygenation. So we'll start with oxygen therapy if it's appropriate. Move them to CPAP and then to mechanical ventilation. In some cases, we may start with mechanical ventilation because they're doing poorly. Move them off mechanical ventilation to CPAP, which is non-invasive CPAP, and then back to O2 therapy. Now, in some instances, we've talked about ventilation in RCP 1-210, and we talked about inverse ratios. Now, quite honestly, we've gotten away from inverse ratios, but essentially high-frequency oscillation ventilation is going to be effectively giving you the same effect, which means it distends the alveoli, and it extends the alveoli to the point that it would be similar to what would happen with an inverse IDE ratio. So we would increase mean airway pressure, essentially, either way. So that's typically how we do it now, is high-frequency oscillation ventilation. So please watch the video Prezi on high-frequency oscillation ventilation following this section. Surfactant installation. Again, we would do this as soon as we could after therapy. And again, I have a Prezi on surfactant installation, so please watch those two following this. We're going to stop after the RDS, take a break, and when you come back, I want you to watch the two Prezis on both therapies. So prognosis is good once the infant makes it past the first 48 to 72 hours. There are possible complications. We can get bleeds, but this is typical for premature babies anyway, for intracranial bleeds. The intracranial bleed is level 1, 2, 3, or 4. 4 is being the worst, 1 being the least, and we want to avoid those bleeds from occurring. But that's because of the weakened system as a whole, but also the fact that early on in their birth, all infants, the more premature they are, the greater the chance of intracranial bleeds. Bronchopulmonary dysplasia, it's something we'll talk about in a separate section, but essentially it's chronic lung disease in infants that had RDS. Lastly, patent ductus arteriosus. Now remember, the patent ductus arteriosus is something that occurs as a result of hypoxemia. If we keep them oxygenated well, this should mitigate this. If not, we can opt for surgery, but also medication to close the ductus. Now, we're going to stop here, and I want you to, before coming back to transient kidney, I want you to watch high-frequency oscillation and surfactant therapy on the Prezi. See you on the other side.